It's not. It's at the best of the times, the right ventricle is a bit of a wuss anyway. It doesn't like to work. It's not a worker. The left ventricle's a worker. You hardly ever can call the left or stop the left ventricle from working. But the right ventricle throws up its little hands at any opportunity to stop working. In fact, you can't increase the pressure on the right ventricle by more than 20 millimeters of mercury acutely.
Yes.
If you don't want it to fail.
So, as Ellen and I just remember again, one of her pearls is, a right ventricle is almost unresuscitatable. So never let the right ventricle stop,
Well, theoretically anyway.
And so, in this instance,
that's why pulmonary embolism patients are so difficult to resuscitate.
So, Ellen, in this instance, obviously, I know we would have done our oxygen high and oxygen low tests. Would you just explain to the guys how we know whether we can test whether this right ventricle will cope once the VSD or the PDA is closed?
Well, the way we test it, in fact, is to occlude it temporarily with a balloon. Well, the oxygen thing is to test whether the pulmonary hypertension is reversible or not. So if the pulmonary hypertension is already irreversible, in other words, irreversibility occurs when there are changes in the pulmonary vasculature itself. And the pressure in the pulmonary vasculature is no longer dependent on the flow.
Okay.
And if you stop that excess flow, then the pulmonary hypertension doesn't go away.
Yes.
And even worse, it usually is at that stage is progressive. In other words, the pulmonary hypertension will continue to develop and continue to develop. And that's, of course, how you get an Eisenmenger.
Exactly. So that'll lead us nicely to our last case discussion.
Yes. So, of course, you have to make sure before you try and close it, either surgically or, in fact, with a device, that the pulmonary hypertension is going to respond.
Yes.
And the best way to test that it's going to respond is to give the patient 100% oxygen.
Yes.
Now, you remember I said it's not a good idea to vasodilate the pulmonary artery.
Yes.
Well, there we are. I have to eat my words. Because you do have to vasodilate them when you do the oxygen test.
Absolutely.
So what you do is you measure the pulmonary vascular resistance at 21% oxygen, and then you increase the oxygen concentration to 100%.
Yes.
After 10 minutes, you test the pulmonary vascular resistance again. By the way, this requires, of course, putting in a pulmonary artery catheter.
Yes.
Because that's the only way you can get the PVR, isn't it? But anyway, we'll leave that little bit out for the time.
Yes, that's for another time. But Ellen, I was just thinking, it just makes me think, you've
correctly.
Yes.
So you have to do the measurements on room air, basically.
Okay. Yes.
It's not entirely true, because if you're really struggling and you can't maintain SATs, they will let you go up a bit.
Yes, we've done a 25% before.
Yes, they can go up. You can go up to about 35%, and they'll make an adjustment in their calculations for that.
Okay.
But a patient, but a VSD who doesn't tolerate room air is already probably teetering on the verge of irreversible pulmonary hypertension anyway.
Exactly.
And I've certainly done a few of those. I remember one little Downsy that I did with a patient with Down syndrome.
Yes.
Who was already this. I mean, I quite like the shade lilac.
Yes.
But I didn't like it on her.
Yes, absolutely. Absolutely. Okay, Ellen. So we've got this kitty, and in the lecture that I gave on Peds Cath Lab, I obviously used the 40-44 rule. So I just wanted you to chat to them about that and just the origin of where it came from and the reasoning behind it.
Okay, well, just a disclaimer. It's my own personal rule.
Yes.
It isn't validated.
Yes.
There's no kind of... But what you need to do is try and maintain the pulmonary vascular resistance where it is. So I like to use 40% oxygen.